Thank you, Scott, for the introduction. Can everybody hear me okay? Right, okay. Yep, good. So I've been told I've got 30 minutes to give you an orthodontic update. It's not really that interesting, all right? I'll be as quick as I can. And so yeah, thank you. I've been at SCED now for about 6 months. A little bit about myself. I qualified in 2001. I worked 5 years in practice. NHS practice here in Glasgow, in Newcastle. I did a year in Australia as well. And then I came back and I decided I wanted to do some orthodontics. So I spent 8 years in the hospital service, doing all of my jobs and everything, and eventually sitting my MO to get my specialist training. So I've been a specialist here in the West of Scotland, based in West Scotland, for about 8 years now. I've been in practice, in hospital, and like I said, I've been at SCED now for about 6 months as well. So let me put my timer on, make sure I try to stick to time. Well, Leslie's gonna rugby tackle me as well. Right, first things first, the dreaded GDC, okay? So if you go back to the GDC statement, a GDP should be competent in carrying out an orthodontic assessment, including an indication for treatment need and timely interceptive treatment and appropriate timely referrals. So it's 3 things there. Need to do an orthodontic assessment, indication for treatment need, and interceptive orthodontics as well. So our job as dentists is always to secure and maintain dental fitness, okay? When I was working on Paisley Road West, this is kind of what I would see pretty much generally throughout my working day. So we'd have patients that are not dentally fit. With respect, I don't think we need to be a fantastic clinician to realize that some of our patients there are suffering from some dental diseases then. So the orthodontics, that's why you get the horrible letters back from the orthodontist. Can you please send the patient back when their oral hygiene's improved or when their dental fitness is improved? Actually, orthodontics is inducing a small pathological process in the dental arch. We're actually making a little bit of disease occurring by inflammation and moving the teeth around. So if the patient is not fit in the first place, and I get to see them, and I make them even more unfit, then we could all get in trouble. So that's why we always want them to be secure and have good dental fitness. And it's my job to make sure that they have good dental fitness during the treatment, and then it's our job collectively to make sure that they have good dental fitness after treatment as well. So I'm going to put a few statements out here that some of my orthodontic colleagues are not too keen on, but I think actually all clinical dentists are orthodontists, okay? It doesn't necessarily mean you have to go through specific registered program of training, but I would want every single patient now that comes into your practice to have orthodontic awareness about what's happening with the occlusion, because these 20 or 32 little teeth that we're looking at, they all sit in, like a jigsaw, they sit and have dynamics, they fit to each other, they bash against each other. We need to understand what's happening with that pattern because it can cause our patient problems. So actually, it's not the obvious ones. Every single one, you should be having an assessment. It doesn't mean a full assessment. It's going to take you half an hour. Just a quick look, get an idea, because if there's a problem, then you can solve it, which your patient doesn't know about. You can solve it, or we can solve it together. We need to help our patients, because our patients don't know this, okay? It's like saying somebody that there's a mole on their back. They can't see it, so they don't know. So it's our responsibility to inform them and to treat them. All GDPs are gatekeepers for ortho. Refer or not to refer? This is the question I get all the time. What age should we refer them? When should we refer them? And I'm going to answer that question. And the days of orthodontics being a dark art and separate, little weirdo people that are sitting bending wires, sitting in the corner, we don't talk to dentists, we don't know anybody, those days are gone, hopefully, all right? Because the reality is that, and that's why I said at the beginning, I'd spent 5 years in practice. I'm a dentist first and an orthodontic second, okay? That's what, there's a big rivalry going on in the dental literature between sometimes orthodontists and dentists. And we really need to get over ourselves, because the reality is, guys, that we're a very, very small group in the healthcare professional service. And if we don't help each other and don't work together, then we're all going to suffer. So, orthodontic screening, timing. So who sees pediatric patients here? Who sees kids? Is it me? Everybody in this room, because I assume we all, not just the patients that come in, we might have children. our own kids, or kids that we're related to. So all kids at 9 years of age, ideally when they're 1s, 2s, and 6s are placed, should get an orthodontic assessment. At 12 years of age, we should be assessing for the upper canines as well. Where do you find this knowledge? You can go to the British Orthodontic website or even your local specialist. Now, I'd like everybody to get their camera phones out because I think it's really important that when you come to CPD, you actually get some really easily digestible information that you can use in your practice on Monday. So everybody get your phones out. Don't take a picture of me. It's okay. I know I'm that beautiful, but it doesn't matter. Because I'm going to give you some Imran's top 12 tips, okay? So delayed eruption, we need to know eruption dates. We don't necessarily need to know them in our mind. We just Google it and it comes up on a PDF. When are the teeth meant to be coming through? So everybody take a photo of it when it comes through. Skeletal discrepancies, okay? We need to stop looking at teeth and start looking at faces. Start looking at the outside of our patients first. What is the skeletal discrepancies in both anterior, posterior, in vertical and in transverse, all three planes of space, okay? All the knowledge that people talk about, aesthetics, you know, all the Botox, all the fillers, implant dentistry that you were talking about earlier on, Scott, all of it's connected. So we don't need to relearn new knowledge. We already have that. We're just using it for different skills. So skeletal discrepancies. Crowding. Teeth can be crowded, and that's pretty obvious. If you can see that picture, I know it's a bit low there, small there, that the canines are quite excluded there. But crowding has a variation. It's mild, moderate, or severe. So we need to know about crowding. Increased and reversed overjet. So what is a normal overjet, guys? How much would the front to back distance between top and bottom teeth should it be? 2 to 4. Yeah. That's European notations, 2 to 4. I'm 5 millimeters. My parents are from Pakistan. I think I'm normal, okay? I'm quite happy with that. It doesn't bother me. So, but I'm out with the realms of the British Orthodontic classification of normality. So I might have an indication for treatment, but I'm perfectly dentally fit and healthy. So I don't need treatment. Just because somebody doesn't fit within the classification doesn't necessarily mean that they need to have treatment. Did everybody get a picture of that? Last one? Don't be shy, guys. Come on. Did everybody get one? Right. Next one, crossbites. So crossbites can be unilateral, either one tooth or one side. Bilateral crossbite, either both sides, left and right, especially posterior crossbites, is very common here in the west of Scotland. And it's to do with skeletal, the way the skeleton, the way the top and bottom jaws fit together. So actually, just because they've got a crossbite, it doesn't mean it's a pathology. It doesn't need to be corrected, okay? But it could be assessed. Deep overbite, the bane of my life, okay? Deep overbites, especially again here in Northern European, the genetics here, most people have an increased overbite. Overbites are very, very difficult to correct. I'm pretty sure when it comes to implant placement, all restorations that you're all looking at, this is the vertical height. The fact that the top and bottom teeth are covering each other, it doesn't give a lot of room for our dental colleagues or even orthodontic colleagues to do the work that we want. Open bite. Is it normal to have an open bite? It's about 5% of the population have an open bite. Again, is it a pathology? Is it causing them problems or not? So somebody's gone on the internet, they've gone on the Invisalign website, they found out they've got an open bite, they come to see me and say, Imran, I want you to reduce my open bite. I say, okay, how much of a problem is it for you? Can you still incise food? Can you still eat properly? Yep. Has anybody noticed it? No. So it's not really an aesthetic concern, it's not really a functional concern, so it doesn't need to be corrected. However, if somebody comes to you and says, I can't chew sandwiches, for example, I find it very embarrassing that I've got an open bite, that might be something that we can correct, whether that's just braces alone or braces and surgery, because a lot of open bites have skeletal problems. I'm going to keep saying it, I'm going to say it until I'm blue in the face. We need to stop looking at just individual teeth. Start looking at faces, because actually it's all a jigsaw, it all fits together, and part of the problems are that we focus tunnel vision as dentists into small aspects and forget that there's a whole picture surrounding it. Digit sucking. So my 5-year-old son sucks his thumb, and my 6-month-old daughter has just started. Hey, it's going to be great, okay? Is it normal? Most children have some digit sucking up to about the age of 3, okay? So again, my child is sucking the thumb, Imran. We need to give them some sort of orthodontic appliance. My way of talking about digit sucking is very, very different to what it says in the textbooks. The first thing you need to do is counsel the patient, i.e. your child, and counsel the parent. It's normal, it does happen. It's a comfort thing. The second thing is that when it comes to digit sucking, there's no point castigating, if we've got kids, there's no point castigating your child to stop doing it. The minute I say to my son, stop doing it, he's going to do it again because obviously dad said something, I've got to go opposite to that. So you counsel them, you say, okay, what times of the day are you sucking the thumb or your finger? As at night time, it's very difficult to stop a habit when they're in their sleep, yeah? But if it's during the daytime, maybe in the car when they're going back to picked up from school or they're watching telly as well, maybe that'll be a bit of time to think about taking the digit out of the mouth and stop sucking the thumb. So if you can break the cycle during the daytime, it'll be easy to break the cycle at night time. And if mum and dad, you go into their bedroom and you see that they're sucking their thumb and they're asleep, just carefully take the thumb out of the mouth. The minute you turn your back, it'll go back in again. But if you can break the cycle during the daytime, I find that a lot easier. And I'll normally review them again 6 months or 12 months later. So what's my record for somebody sucking their thumb? Age record. What do you think the oldest patient I've ever had? Sorry? 75. Right? And they've been referred to lots of people, lots of orthodontists, and they've had orthodontic treatment, they've closed the anterior bite, but you've not dealt with the etiology. The fact is that they're still sucking their finger, and that's what's causing the anterior open bite. So we can put fancy braces on, but we've not dealt with the problem. We've not even understood what is the etiology, the cause of it. And again, that's about speaking to your patients. Canine positions, very important. Submergence of teeth. Teeth of poor prognosis, classic here in the west of Scotland. Caries 6s, to extract, not to extract, what we're going to do. And hypo or hypodontia, too many teeth, too little teeth. So these are my top 12 tips. They're not all my tips, obviously. I've taken it from other presentations and what I've learned. But at the end of the day, if you've got these 3 slides, you can upload it onto your practice management software, onto your desktop. At least every patient that's coming in, you're thinking about these things. So, deciduous tooth extraction, I would say extract deciduous teeth 12 months after expected exfoliation. When's expected exfoliation? You just go on to the chronological PDF file from the British Orthodontic Society website and find out when the tooth was meant to fall out. So if a patient has got E's and D's and they're still in single figures, that's fine. If they've still got E's and D's and they're 42 years old, we need to understand there's a problem going on here. Yeah? We need to understand that there's a difference in the chronology of their exfoliation. Why has that happened? Let's take some investigations. Extract any deciduous tooth at 14 years unless a compelling reason to leave in situ. There's a constant debate about balancing, compensating extraction. Again, I'm very minimally interventive orthodontist. I think we try to save the teeth as much as you possibly can. The old days of taking out lots of teeth and everything will sort itself out. Well, I'm the person that's having to sort that out. As an adult patient's a lot more hard to treat than children. So what is orthodontics? Is it treating children? Is it treating adults? Or is it inter-multidisciplinary care? So here's a wee patient, come in, 14-year-old boy. Tell him to smile. This is the kind of smiles that you get. Got the fuzzy bum fluff on the top lip as well. And he's got retrognathic mandible. It's a class 2. Look inside the mouth. Teeth are quite well aligned. But what's his presenting complaint, guys? Front teeth are stuck forward. Okay. Yes, he has an 8mm overjet. Okay. And using the NHS classifications, the IUTN classifications, he would be applicable for treatment. So yes, we can, when they're at that age, when they're growing, you can do some functional appliance treatment, and you get quite a nice result at the end. Okay, you can get everything into a nice class 1, everything interdigitates. As long as he wears his retainers, he should be dentally fit and healthy and maintaining his retainer, whether it's myself or my dental colleague, and he shouldn't have any significant dental treatment for the rest of his life. I think that's a dental success. Okay, we can talk about all the fancy stuff that we do as dentists. That's a fit dental patient. That's what we want as a success. Or is it treating adults? So here's a patient, adult patient. Again, a lot of crowding. He's had some restorations in the past. I haven't got his periodontal classification, sorry, Jolene, but I'll try to do that next time. But he doesn't like the fact, especially with the social media, we're all aware of the way things are nowadays, taking photos, selfies. He doesn't like his smile. We can take some teeth out. 2 teeth taken out, 2 premolars taken out, and a lower incisor extraction, quite an unusual treatment plan, and upper molar fixed, and a reasonable result. Okay, again, he needs to make sure he wears the retainers, and his bond retainer is being maintained by the dentist, but he needs to wear his retainers because if you don't, he's going to get relapse. Or is it this where somebody's had a canine that's stuck under the gum? We send them off to either myself or we send them to the hospital, and we do some surgical exposure. We try to align the teeth to get the canine to the right position. Again, if that's spotted early, the fact that this canine is not erupting properly, we could have taken out the deciduous canine and maybe saved them all these problems in the first place. So about spotting things early. I actually think orthodontics is all of these and more. Unfortunately, there's been a lot of head burying in the sand over the last 5 years because a lot of orthodontics has now been done in practice as well. There's this big dental fight between orthodontists and dentists, the fact that dentists shouldn't be doing orthodontics. Well, we all pick our cases. In that way, we could say that dentists shouldn't be doing anything. We should all be specialists in certain aspects, specialists in implantology, specialists in endo, specialists in perio, but we're not. So actually, the reality is it's possible to do some mild orthodontics in practice. So I do quite a lot of teaching with dentists called GDP orthodontics. So let's see if I can get this video playing. So this is a case that I worked with my colleague. So we took some pictures. We worked out where we would like to put our brackets. So we made some lines. Look at the angulation of the teeth. You can even see the fact that the teeth are worn. So first of all, he wanted to align the teeth. This is where we're going to put the brackets in. The brackets are handles, essentially try to move the teeth around. Get the teeth aligned, get them whitened up, and then do all the lovely, fantastic operative dentistry that you guys do. I mean, I couldn't do any of this. So, quite a nice result, patient's happy. So, referrals. Personally speaking, dental fitness, like I said, is always pre, peri, and post-treatment is paramount. If in doubt, and again, I'll probably saying things that my other orthodontic colleagues are not happy about, I would suggest you please refer in. I'm happy to see patients at any time. Okay, I got spiked by PSD, Practitioner Services Division, because I was doing the most number of orthodontic reviews in Scotland. I wasn't claiming money for them. I wasn't doing any fraud, guys. I was just seeing the kids again and again. I'm a bit OCD that way because I was putting the green forms in, they were getting annoyed I was putting the green forms in because they were saying, why did you keep putting all this, wasting all this paper? Because we're still paperless, guys. Unfortunately, orthodontics in Scotland is still paperless. So I got spiked because I wanted to, I can't just see some kid and just say, I'll see you again in 3 years' time, or re-refer them when the premolars come through. I wouldn't do that to my son, so I'm not going to do it to anybody else's kids. So I'd rather see the patients relatively regularly, every 6 or 12 months, just to keep a close eye on them. And there are very strict rules, NHS regulations, for adults and children in Scotland. But we are still lucky in Scotland that some of our children can still get good quality, high quality orthodontic treatment under the NHS. So in SCED, I am the only person that does a little bit of NHS work. Everybody else is a private dentist, but I've managed to get a list number with SCED, and so we do offer NHS orthodontics for those patients that are applicable. So I can see all children, and I will see all children for NHS assessment. Unfortunately, there is a very strict selection policy, which goes through an indication of orthodontic treatment need. We need to go through that policy, see whether they actually fall within the guidelines or not. Processing time takes a bit of time with Practitioner Service Division as well. It takes about 3 months. And if it comes to fixed appliances, then you cannot get cosmetic ceramic appliances. You can only get stainless steel brackets, which are absolutely fine, guys. Okay, so the actual care is the same. It's just the brackets that are different. But you cannot get ceramic white braces on the NHS. So here's Rebecca. She came to see me. She was the patient that we showed earlier on about crowding. We took out 4 teeth, upper and lower fixed appliances. And hopefully Rebecca, that's 5 years ago now. I think she's at university now. Hopefully she's still wearing a retainer. And we've got a reasonable result there. If the children have had an NHS assessment and we've tried to get them approved and that's not possible, then we do offer what I call independent treatment, okay? Generally, those patients, their malocclusion would be not as severe as the patients that are applicable under the NHS, but there's no selection policy, there's no processing time, and we do offer white ceramic brackets if they have some aesthetic concerns. And like I said, the treatment quality is the exact same because it's just the brackets that are changing. Imran's not any different, Lauren's not any different. We're still the same people that are looking after the patients as well. Adults. So adults, it's interesting, I've been at SCED. I would say I'm probably about 70% adults, 30% kids now. That's probably my sort of proportions. Some adults are still happy to have, if they're going to have fixed appliances, are still happy to have stainless steel brackets, but the majority would like to have something a little bit more aesthetic. So here's a patient that unfortunately slipped through the radar as a child. As a child, they definitely required some orthodontics. They slipped through the radar. And when you start speaking to your patients, you find out that maybe their lives were quite challenging at that time. They moved around a lot maybe. They didn't see the dentist. That doesn't mean that they shouldn't have access to good orthodontic, good dental care. Just at that young age, unfortunately, life was a bit more challenging for them. So again, this patient, we did a lower incisor extraction, and premolar extractions, and upper more fixed. Here's another patient. This is an adult patient, and all they were interested about was the imbrication, the rotations of the upper central incisors. So we did some upper and lower fixed, upper fixed, and got a reasonable result. We accepted the fact that they've got a little bit of lower incisor crowding. And about a year later, the patient came back and said that they wanted to have their lowers done at the same time. It's always better to have upper and lowers done at the same time. It's less expensive as well. It makes my life a lot easier as well. And obviously, we provide aligner treatment. Now, if you do Google searches and stuff, then Invisalign is the big market leader in aligner treatment. There's actually a variety of aligners out there. Invisalign is just a trade name. Invisalign is just a trade name, but it is a very good system. But it's only applicable for certain types of malocclusions as well. Okay, so one size doesn't fit all. That's what we realize in dentistry. So for certain malocclusions, Invisalign is quite good. For certain patients and their lifestyle as well. We had a consultation yesterday. This gentleman, he does a lot of traveling for work, does lots of presentations. So fixed appliances was not something that he was overly keen on. He was thinking about some sort of aligner therapy. However, aligner therapy is not good at relieving some malocclusions as well. So one size doesn't fit all, and that's why it's good to get a full orthodontic assessment and give the patient all their options, then they can make the decision. Almost done. So conclusions. How am I doing for time, Leslie? Am I on time? Oh, okay, all right. So I'm happy for any referrals because I like to see patients. I'm happy to see children or adults. And my advice would be, if anybody's interested in orthodontics, is certainly not a separate part of dentistry. We all need to continue with our learning. That's what today's about, all about our learning. There's plenty of courses out there. There's plenty of things out there. Get in touch with your local specialist. You can even get in touch with your local hospital, or there are actual dedicated training pathways as well, whether it's a formalized pathway that I went down or something that might fit into your own practice lifestyle as well. But it's a really fantastic, I know I'm being a bit boring here, but I actually really love what I do. And I really thoroughly encourage everybody to actually integrate it fully into their practice. I think that's me all done. All done. Thank you. Thank you for your time. Have you any questions?